So with all your due permission, we are live. Can we begin?
Yeah, can I go ahead?
Yes, sir. So I'm beginning with the session, sir.
Yeah.
Good afternoon, everyone. This is Batul from IGCP, and I would like to welcome all the viewers who have joined our platform for the better exchange of knowledge that is going to be shared by our keynote speaker, doctor, for today's session. With great honor and pleasure, I would like to introduce none other than Dr. N Ravishankar, sir. Sir is MBBS, DFM from Colombo, FCGP, PGD MLE, MBA, and family physician at Sudar Hospital, Chennai. With the help of sir, we'll be taking a close look on today's topic, which is consent in medical practice, medico-legal. So before moving on to today's session, let us have a brief look on what the topic says. Consent in medical practice is a fundamental ethical principle that upholds a patient's rights to autonomy and self-determination. It involves obtaining explicit patient permission before conducting any medical procedure or treatment. Informed consent ensures that patients are adequately informed about the risks, benefits, and alternatives, empowering them to make well-informed decisions about their healthcare. We'll be learning more about the consent in medical settings. So now, without any further delay, I would like to welcome sir at our forum and would like to hand over the session to him for his talk to begin. So over to you.
Thank you. Good afternoon to all of you. I'm getting my slides on. And it's a tough topic on an afternoon session, post-lunch, trying to sit and listen to something away from the medical fraternity that is a bit of legal issues that we need to know in our day-to-day practice so that we do our practice without any difficulty. Law is one which has not been of good taste to us. It's neither bitter nor sweet, but it has never been palatable for us. But there's one thing in our practice that we need to follow is the legal compliance that is there in our profession. The legal compliance is being given to us by the Code of Medical Ethics after our graduation, and then the law that is existing in the country, we need to follow it. And today, we are only a service provider to the consumer, and that consumer is the patient. Next slide, please. And providing excellent care every patient every time has to be our mode of professional work here. And what is the most important thing? The healthcare consumer have changed a lot. Digital technology, the vast amount of information that people can gather in the shortest time has made the healthcare to also to change. Patients are now better informed. They want to understand their medical care. They Google it and get the information on the Google. They always think that Google is something going to give them an unbiased opinion. But then a clinical opinion can only be given by a medical practitioner sitting next to you. Patient wants to be part of the decision making in their care, which were never there nearly 3 or 4 decades ago, that they allowed the doctor to make the decision. But today, patients have the right to make the decision and they want to make the decision. Patients are much more questioning of the process. They introspect us, they put us for a lot of questions to give them a justifiable answer to proceed on the process that we want to do for the patient's recovery. Healthcare has been increasingly spotlighted by the media, so patients have higher expectation. It's not the patient alone. The science have grown to such an extent that patients expect the healthcare community to give them back to normalcy what they had prior to their ailment. The next slide, please. Medical negligence is known to everybody. The one bad vocabulary which we always hate, and there are 2 giant killers for that. One is improper consent, and subsequent to the consent, improper documentation, which is the cause of more than 50% of the consumer case that goes to the court. Next slide, please. Consent is just a legal requirement of medical practice. It's not a just, it is a legal requirement of medical practice and not a procedural formality. We always think trying to make things differently. Why should patient put us on the legal angle? But then today, everybody has got the right to know everything. We ourselves will like to know how your mobile works. What are the facilities in your mobile? And how do we go about it? And that is where the same thing. if a patient is rushed into signing a consent without giving sufficient information, the consent may be invalid despite the signature of the patient. This is a statement which I think everybody will be thinking twice. Why? When somebody has put down the signature, how is it they go back on their word? But then science is something so different. Even when we go to the court, the patients go to the court, the judges depend purely on the medical fraternity to update them, to decide on what is the right course or what is the wrong course. In such a situation, patient has also got the right to know all information before subjecting them for any treatment. And so let us understand that consent is just not a procedure that we do on the patient. It is a legal formality that has to be done with both the spirit and the value for it. Next slide, please. Consent. The following important points are there. Every patient has a right to full information. If you say he has got a myocardial infarction, you need to tell him everything about myocardial infarction. Right from the causes, the pathology, the physiology, the biochemical changes, what is the therapeutic options, what is the diagnostic options, what are the options that are left if there is no treatment. All these things will have to be given to them before you get a consent. And that has to be comprehensive. You can't take hours together like teaching a medical doctor. It has to be concise, precise, in non-medical terms. Everything about this diagnosis, treatment, and prognosis. And if they are not going to have the treatment, you need to tell them about the alternative that is available. Even in the other system of medicine, it is high time if they don't want your system or our system of medicine to choose their choice of medicine. And finally, possible complications and risk involved will have to be told to the patient. Patient has a right to make informed choices about his or her health care. A responsibility to explain and counsel lies on the doctor, and patient can change his mind, give or withdraw his consent at any time at his will. Next slide, please. These are the most valid consents that are there in our practice. Implied consent, informed consent, express or an oral consent, and a written consent. In simple words, when a patient walks into your clinic and says the complaint what he has got, it is an implied consent that he wants a treatment from you. That is where the contract starts between a doctor and a patient. That's an implied consent. And then you're trying to examine the patient, trying to do a PVPR. There they give an expression. You need to tell them that I want to test this organ, I want to test you this way, lie down on the cot, and then they give an oral consent, and that is also called an informed consent. And when you try to write down what are the things that we already said about the possible diagnosis, treatments, alternatives, everything on a paper, trying a medical legal document, saying that all these things will be done by you in a written format. And when there is a written format, the person who executes, that's me, the doctor, and the person who accepts the patient, both of them should have to sign in front of a witness who has to be a neutral person. More than being a neutral person, he should not be the person from the hospital side, nor from the doctor side. That's very important. We'll see a little later. Next slide, please. The most common mistakes that happen in our country is when the patients get admitted in the hospital, we try to get a consent in the reception. And that is a general concern at the time of admission. It doesn't give you the right to do any procedure on the patient. It just allows you to put the patient in the bed in the hospital and try to communicate with him and try to treat him after getting a consent. Please understand. But taking consent from parents, spouse, children above the age of 18, relatives of an otherwise competent adult person is all invalid. And these are the common mistakes that happen in our country. When the patients get admitted to the hospital, somebody brings the patient and put down the signature in the reception for getting admitted. It's valid at that point of time because he is the person who has accompanied the patient. But then that does not give you the right to do on any procedure on the patient. Next slide, please. Separate specific and written consent. Even the smallest and most innocuous intervention. You want to take withdraw a blood for an investigation or take an urine sample from the patient. You need to tell them, get an oral consent and then proceed. Investigations, diagnostic procedure that requires intervention. You are trying to give an injection dye and trying to do an X-ray. You need to take a separate written consent on for that. And each type of anesthesia, you might plan to surgery on a spinal anesthesia, but halfway through the surgery, you might have to change to a general anesthesia because of the procedural difficulties or a prolonged surgery or the lack of anesthesia with the spinal anesthesia. In that situation, it is better that you take both the anesthesia for a spinal or for a general anesthesia at the time of counseling the patient in the ward and before shifting the patient to the theater. Each of the anticipated alternatives, newer drugs or techniques, all these things will need to have a separate concern for each and everything. Each of the alternatives, you plan for a surgery, an appendicectomy, but halfway through the surgery, you might have something different. If it is not going to be an emergency, then you don't have the right to proceed on the treatment. This is a classical Indian case towards the end of the lecture. Blood transfusion, every single unit of blood to be transfused in a 24 hours will have to have a concern for the same. Starting from 12:01 a.m. to 12 midnight, you need to have a concern for a blood transfusion. If it is going to be a component, you need to have a separate transfusion because the side effects or the complications expected for a whole blood transfusion is different, for a packed cell transfusion is different, for the components or for the factors are all different. So you need to have a separate concern for 24 hours for every transfusion that is being done in the hospital for the patient. These are things which have not been given in the code of medical ethics. Of course, there are certain things which are given. These are all judicial law that has happened in our country with a number of judgments that has given lessons in the country. But then the next point is totally different. Sterility anticipated. What the code of medical ethics says that if there is going to be a sterility that is anticipated, previous slide. It is going to be anticipated, then you need to get the concurrence or consent of both the partners. But then the Department of Health and Family Welfare says for a family planning surgery, the concern of the concerned person alone who's undergoing the surgery is adequate. If it is going to be the female signature. If it is going to be the male signature. It is because it is a national policy to reduce the population. So the two different terms, two different ideas are being given on sterilization. But to be on the safe side, as a medical practitioner, it is ideal to follow the code of medical ethics, which says that we need to get the sign of both the partners. Next slide, please. This is the only place in our practice that we don't need to get a consent from anybody. When you suspect the death has to be assented with a cause, and you find that there is going to be a foul play or something in it, it is there the right of the doctor to request for a postmortem. And that point of time, you don't need to get a consent from anybody, except in a patient when it is going to be an autopsy to find the pathological diagnosis. At that point, you need to know. You need to get a concern of the attenders, the next of the legal hire. But when it's going to be a suspected death, death under suspicious circumstance, broad dead, all these situations, you have the right to request the police to transfer for a concern, for a postmortem. And that's the only place where you don't need to get a concern. Next slide, please. Consent form, that's a record which we have in our hospitals for years together to substantiate the work that we have done, in which the form need to have the diagnosis, the nature of the patient's illness or injury, nature of the proposed concerned treatment and procedure, nature and purpose of the treatment that has to be given, the inherited and special risks that involved, the known side effects, probability of success, all need to note down in the consent form. Only if the patient is being convinced on all these things, do they put down the signature, and then only we can proceed for the surgery or any procedures. Next slide, please. Time for concern, the time for recovery will have to be told. Any alternative methods and its associated risk and benefits will have to be explained. Risk and prognosis, if no treatment is rendered or procedure performed, date and time when treatment will commence or procedure will be performed will have to be clearly told. Number of times the patient is advised an LSCS. You propose the time at 4 o'clock, you tell them to give the consent in 5 minutes, they may not give it. If they give it at 4:30, please note down in the case sheet at what time you have counseled the patient for an LSCS. 4 p.m. At what time they gave you the consent for the surgery? 4:30 p.m. 30 minutes is a big time for so many events to happen for the mother and the baby. Be careful about it, because tomorrow anything happens, they say we gave the consent at the time when the doctor said. But the fact will be it would have been 30 minutes delay, and 30 minutes delay in the pregnancy. Yes, so much can change for the mother and the baby. Next slide, please. Now you know both the added photographs will tell you what it is. Signature of the patient, doctor, and witness. It is not if required, it is required. Date and time when the consent is given or signed is absolutely needed. What I told you earlier for the previous slide. Next slide, please. Taking consent step by step. Assented whether the patient has the capacity to give a consent. Communicate in the language understood by the patient. If it is going to be, there are people who live in the borders of the states. My state, which speaks Tamil, but we have umpty number of people who speak Telugu, who speak Malayalam, who speak Kannada, and now we have a lot of people coming into our state for worker labor. Hindi is absolutely known to everybody here nowadays, and so all the language known to the patient must be told. Provide all relevant information to the patient. Give the patient enough time to give consent after counseling, especially for sensitive procedures, not for an LSCS, not for a stunting or a bypass surgery in a case of emergency. In a case of emergency, please note down the time when you have counseled the patient and at what time the patient has given you the consent, which is a very, very important point. Take a written consent signed by the patient. When the patient is conscious, oriented, it is the patient who has gives a right for you to proceed on the treatment. Next slide, please. There is something called proxy consent to be given for the minors. Somebody who's 12 years below of age for an appendicectomy, consent of only guardian even for MTP. Between 12 to 18 years, consent of both the guardian and the patient. And somebody who's above 18 years of age, consent of only the patient is adequate. And if there is a dispute between the parents, consent of any one of the parent who is thinking in a normal sensorium to provide the best of treatment for the child, their consent need to be taken. And at this point of time, it is recommended that you take at least 2 witnesses from the family. Witness will have to be only from the patient side always. Next slide, please. Next slide, please. Valuable points when you are trying to enumerate in the consent is that it should be procedure specific. It's hysterectomy, it's hysterectomy. When you are trying to add on certain procedures, oophorectomy, yes, add on oophorectomy. If it is GB pathology and you're going to do a cholecystectomy and an additional appendicectomy, write down both the things and do it. And if you are not doing an appendicectomy, then you don't have the right to remove it. It's a surgeon's choice, but then if it is a patient's decision to do it or not. If it is going to be a diagnostic procedure, only diagnostic procedure. And if it is going to be some therapeutic that is being given as an injection, a chemotherapy, only chemotherapy you don't do a radiotherapy. Don't think it's a patient has got a malignancy. Both the treatments are going to be better for the patient. Both the treatments are different. They have different side effects. They have different complications. And so you need to have a separate concern for both of it. And if you can't treat the patient or cure the patient, if it is going to be palliative care, write down in the written consent that there is no specific treatment available. We are just providing palliative care and get and follow the treatment. Tomorrow they might come and say, I have accepted for the treatment, expecting the patient to be cured. Where palliative care, there is no cure, and that has to be noted down in the consent form. Next slide, please. Some of the fallacies that commonly happen when you're taking a consent is, we always think it is a trivial procedure, a small sebaceous cyst that we are trying to remove, and you don't take a consent. But then you're trying to give a local anesthesia, patient goes in for shock, and then in the ICU for 2 days, expenditure there, health is spoiled, and then that is going to be a legal angle because you have not taken a concern for it. This is a common thing that happens in any practitioner's outpatient clinic, be it a surgeon or a general practitioner or a plastic surgeon or whoever it is. When you are putting the knife on the patient, you need to take a concern for putting the knife on the patient. Otherwise, it amounts to murder the patient. You know, section 402, intention murder. Consent of relative is taken instead of the patient, even when patient is competent and adult, which is a biggest failure, because we try to follow the patient's attendant who are more cooperative, who are willing to sign down, and that attendant will always be encouraging or will be forcing you to take his signature. Then you think that is enough, but that is the biggest failure that happens in our practice. Consent in minor intoxication, unsound mind, black and consent is taken, which is not at all valid, and it is not a procedure specific also. Blood transfusion, consent for blood transfusion is most often not being taken, and be careful about it. Even if it is intraoperatively, prior to a surgery, try to take the consent. In case you have not taken, at least come and explain the situation after the surgery and then take a consent for the same. Fresh consent is not taken for a repeat procedure. I already have a slide for it, but then every time when there is a consent taken on the previous day, the next day the procedure has been postponed. It is better, or it is legally correct only if you take a fresh consent on the next day. Procedure related to necessary information is not given, then you don't do the procedure. Even if the information given, it is not documented, please don't do the procedure. Consent lacks a signature of the treating doctor. Today, courts have come. Nearly 10 years ago, this statement was not there. And that at point of time in the international arena, the signature of the doctor was needed. But now today, the Indian courts also have started following that the patient has got the right to know the treating doctors has expressed his concern to treat them, or who is the doctor who is treating should be known to them. That is why the signature of the treating doctor also should be there. Consent is not witnessed. If there is no witness in the consent form, then the form becomes invalid. Alternatives and additions are made in the consent form without patient signing authorization, then the consent becomes invalid. Next slide, please. Some of the proxy concerns: children, intoxication, emergency sedated, alcoholic, insane person. I think we already seen it. Next slide, please. Next slide. This is only a repetition. Sorry. Next slide. Precautions in a proxy consent. Record clearly in medical records the reason for taking a proxy consent. Patient is intoxicated, hence a proxy consent is taken. But to prove the intoxication, take a blood sample, store it in a refrigeration. At a necessary point, please do the test and have a value for it. It is necessary to prove it in the court of law. Not taking a proxy consent, not having a document for the same is not valid in the court. Mentally unfit patient insists on certification from a psychiatrist before taking the guardian's consent. If you are going to be a multi-specialty hospital, get the psychiatrist's opinion, get a signature down on the case sheet, and then go for a proxy consent. In a government hospital, the patient is brought without any attenders. The administrative head of the hospital, the medical superintendent or the resident medical officer can give a proxy consent for the patient at that point. Next slide, please. Proxy consent in emergencies, do's and don'ts. Take decision on the best interest of the patient. If there is going to be a crush injury, I always recommend to take use your smartphone, record the event, the date and time. The patient is going in for a hypotension, bradycardia, is dying. Have a recording of the same camera, the recording of the event that is happening in the monitor. Then proceed on to do the emergency procedure of amputation or whatever it is. At that point, this is enough for you to get a consent when the patient is unconscious and no attendant by the side. Proceed with oral consent or without consent if there is going to be a problem. Record specifically and elaborately in the patient's medical record the fact that the consent is improper and the reason for the improper consent. Improper consent is this is an emergency consent. That is why. Next slide, please. Filling the form, be careful about it. Do not change the pen. Don't use a whitener. A whitener has no role in a consent form. Please see to that. If anything is wrong, strike it down, write it down again at that place. Avoid alterations, additions, or eraser. Will fill the consent while filling the consent form. Patient, take the patient signature on every page of the consent form. You know the bank procedure, they take the signature on the right hand side, left hand side, bottom, if they allow even to the top of it. But then we don't even take at the bottom of the page. That's the biggest defect of the medical fraternity. Take the patient signature initials whenever handwritten or typed entries that are changed in the form. Please see to that you get the signature. If you have not done it during the procedure or prior to the procedure, at least after the procedure, counsel the patient that we need to take signature in more different places and explain the thing and then do it. Be transparent. When you are transparent, you are accepted. Only when you are trying to hide facts, then the patient will have doubt about the whole procedures. Next slide, please. Do not leave any blank space thinking that you can fill it later. Even if you leave a blank space, before the case sheet goes to the MRD section, strike it down or fill it something and then do it. Record specifically the patient's delay in giving a consent, which I already told about it. Next slide, please. And if there is going to be a complicated, previous slide, please. If it is going to be a complicated procedure, 2 witnesses are needed. If they have come only for a specific surgery, the different surgeons, different anesthetists, different specialists coming for different procedure, from what time to what time, what are the procedure done by them, all these things will have to be separately written in the consent form, at least after the surgery, just to know if there is going to be a complication in the polytrauma with a malunion. Why should the general surgeon or a vascular surgeon be involved in the case? They can always be taken away from the case, quoting that this is a person who's an orthopedic surgeon. You don't need to get the summon for every one of them. Trying to help your own colleagues, and if these colleagues are outside, they can always help you morally on academic aspect also. Next slide, please. Local language, everything is known, information in the language, and there are different things for an illiterate patient. Some illiterate patients put down a thumb impression. If they put down a thumb impression, note down whose thumb impression. Witness the person who knows the language or who can understand the language or who can understand the written what is being there. You have another illiterate putting down a thumb impression on the witness, then I think it is very difficult to convince the court that they have been given all the necessary information. There may be a person who knows the language Hindi, but then he will put down a signature in English. That's the way how all these people escape the courts. They come to the court and say, I don't know English, I know only Hindi, but they asked me to sign, so I signed. The witness will have to be a person who knows both the language, English and Hindi, and who can understand and give all the necessary information to the patient. And then that witness is more valid in all these things. And if there is going to be a complicated procedure, complicated patient, somebody who asks lots and lots of questions, 2 independent witness from the patient is much better. Next slide, please. It's all the same, more procedures, get consent from every person, all these things. Next slide. And if there is going to be an extension of the procedure, and if you suspect that you can't proceed on with the consent, what do you expect? You have a bad appendix, you have a CT report saying there is a perforation, synapses formation, all these things. Then you try to explain it in the consent form, and you might have to go for a hemicolectomy if needed. In that situation, anticipate it and note it down in the consent form. It's not wrong. When you come back from the surgery, if there is no colostomy or anything done, you can always strike it down and get a countersign from the patient and keep the consent form for your sake. Next slide. MTP, I think everybody will be knowing the consent of the spouse is needed, the patient is needed, about 24 weeks, there are a lot of implications. And very important here is, and if you are trying to do an MTP for a woman, try to counsel them all alone in the ward or in your OP or in your consulting chamber at least once. before proceeding on the procedure and note it down in the case sheet or the OP slip saying consent, concurrence, signature, obtain, counseling the patient all alone without any attendant in such and such a place and such a time and signature obtained. Tomorrow the in-laws or the parents or somebody will come and say totally different thing and the patient will react in a different way. So at that point, it is necessary that we need to have the consent of the person who undergoes the procedure all alone. It may be a forced thing. Tomorrow the lady has got the right to go to the court and sue us. Next slide, please. Next slide. I think it's all done. Guardians of incompetent patients retain the right to refusal. Even prisoners have the right to refuse for the treatment. You can't force a prisoner or you can't force a minor when the guardians withdraws the treatment process, consent or whatever it is. The patient has got the right, and in the proxy situation, the guardian has got the right. Even prisoners have got the right to refuse for treatment. Next slide, please. I think we have already seen it, an invalid consent, the blanket consent, a fresh consent. All these things we have already seen. But then surgery was a anesthesia. Today, we need to have a separate consent for anesthesia. Everybody will be thinking, what is it that every single procedure, every single person involved in the treatment is now going to keep signing everywhere. Tomorrow they may come, the situation may come that who is the treating doctor in the ward or DMO also will have to sign before looking into the patient. This is a changing scenario in the world. The health sector has also changed a lot. So the things have to change according to the law of the land. According to the law changes according to the need of the citizens. And that is why surgery anesthesia and anesthetist anesthesia consent is also necessary, is also a must in today's practice. Next slide. Now we come almost to the last scenario. This is about a real concern. This is a case of Samira Kohli versus Prabha Machandaya. The value of the real consent was come into force. The stringent informed consent became applicable subsequent to this case. Next slide. Let me go to the case scenario, which will be an interesting one. After a dull talk on a consent of the legal formality. Next slide, please. This was a 44-year-old spinster who had an excessive bleeding PV. An ultrasound abdomen was done with an enlarged uterus. The patient was admitted for diagnostic laparoscopy. Follow it, admission for diagnostic laparoscopy. Consent was taken for a diagnostic and operative laparoscopy. Intraoperative, the assistant surgeon came out of the OT to get signature from the mother for hysterectomy. They saw the entire abdomen with a lot of seedlings, mesenteric seedlings. They thought, why should this patient have to come back again after confirming the diagnosis for another procedure, and cost of procedure will be less. So they took up the case, went out to the mother who was there. She was a spinster, and then finally they thought, what is the wrong in doing an hysterectomy for that person at the age of 44. Next slide, please. They got a consent for the hysterectomy. They proceeded on the hysterectomy, and the patient recovered for the next 3 days. Nothing, no problem was there. They have been paying the fees regularly. Next slide. At that point of time, this 44-year-old woman got her boyfriend or an elderly friend or whoever you can call, whichever way. Next slide, please. The man came, saw that the hysterectomy has been done. 44 years, this man was also somebody who was 50 plus, was an ex-serviceman. They thought of getting married after the surgery or whatever it is. And then at that point of time, he took away the patient from the hospital, not paying the bill of 24,000 due to the hospital. This case was almost decades ago, more than a decade ago. At that point of time, the hospital went and filed a complaint in the police station for the recovery of the fees. And then that person who was the accompanying a male member, male boyfriend or the gentleman friend, then filed a complaint in the court saying, to be spouse have undergone a surgery of a mutilating surgery without taking the consent for an operated for doing an hysterectomy. This was the case, and the case went up to the Supreme Court, went up to the National Forum. Finally, the judgment was pronounced saying hysterectomy was needed for the patient. Next slide. Next slide, ma. Hysterectomy was needed for the patient, but then consent was taken only for a diagnostic lab from the patient, while for hysterectomy it was taken from the mother. And so it is not valid that the person who is undergoing the surgery has not given her expression or not given her consent for a hysterectomy. So it is not valid, and that the court said, of course, the patient would have need to undergo a hysterectomy, should have to undergo a chemotherapy or whatever it is, but then consent was taken only for diagnostic lab. Proceeding beyond the diagnostic lab is not fair, because it is not an emergency to proceed on at that point of time, as there was no life-threatening problem. It was only a diagnostic procedure. They could have done the biopsy, come out, confirm the diagnosis, and then proceed on an hysterectomy. Next slide. Next slide. Next slide. The whole story is given in different slides. See the last red letter that has been given by the court. On the facts and circumstance, we consider that interest of justice would be served if the respondent is denied of the entire fee charge for the surgery, and in addition directed to pay 25,000 as compensation for the unauthorized bilateral Sanfingo oophorectomy surgery to the appellant. Consent was not specific for hysterectomy. Consent was not taken from the patient, it was taken only from the mother. I think a lot of things which I told about the consent is all seen in this one single judgment. So now you can understand the value of a consent. It's a 44-year-old lady. What is the percentage of success of conceiving even at that age after getting married to somebody who's 50 plus or whatever it is? Elderly, infertility, chances of malignancy, chances of secondaries, all these things are there. Still, the court saw the only view is a concern. It was not a valid concern. It was an improper concern. Concern from not the patient. All these things have favored the court towards the patient and against the doctor. Understand now the value of consent in our day-to-day practice. Next slide. And you need, when you're trying to give some publications, a registered medical practitioner is not permitted to publish photographs or case reports of his or her patients without their consent in any medical or another journal in a manner by which their identity could be revealed. However, in case identity is not disclosed, consent is not needed as per the Code of Medical Ethics 717. This is for publication. The next slide. Next slide, please. It's for research. Consent taken from the patient for the drug trial or research should be as per the Indian Council of Medical Research guidelines. Otherwise, it will be constituted as misconduct. Next slide. I think that will be the last slide. What is the character of a professional, the medical professional? The nature of the work, which is skilled and specialized, and the substantial part is mental rather than manual. Commitment to moral principles which go beyond the general duty of honesty and wider duty to community, which may transit the duty to a particular client or patient. Professional association which regulate admission and seeks to uphold the standards of profession to professional code and matter of conduct and ethics, etc., etc. But then legal compliance, ignorance of the law is not a defense, and legal compliance is part of every profession. It's not for medical alone. It is for the chartered accountants. It is for the architects, and even for the people who are registered in the Bar Council. And let me thank IJCP for giving me an opportunity on this afternoon to speak to you all on a common topic which you always neglect. consent in our practice. Thank you very much.
Thank you so much, sir, for your comprehensive talk on such an important topic that you have shared today.
Thank you. Thank you. Are there any questions in the chat box?
Yeah, sure, sir. Is my voice audible to you, sir?
Yeah, of course, no issue.
Okay, sir. Just give us a minute, sir. We are putting down the questions.
Yeah.
So the first question that we have received is from Dr. Radhika, and she wants to know what is implied consent.
The terminology gives the word implied. When somebody comes and talk, it is implied. In your outpatient practice, when I told you earlier about it, in an outpatient practice, when the patient, how does a contract comes between a patient and doctor in outpatient practice? Is only because of the implied. It is implied that the patient, when the patient gives his complaint, it is implied that he wants the treatment from the doctor with whom he is expressing it. He expresses and it becomes an implied concern. That is what it is.
Thank you so much,
sir.
sir.
It is all the vocabulary that it plays the value there.
Thank you so much, sir, for answering this question. We have received another question. I have put that question in the chat box for you, sir, since it's a big question, a broader question.
I see it.
Yeah.
As in the past, it was sort of unwritten rule, their consent to examine a patient by all four methods. As per our training, there was no written or even verbal consent. In today's practice, do we have to take a written consent for every patient? That is why I say implied consent, express consent and implied. He expresses his complaint. It is implied that he has given a consent for the treatment, or a verbal consent is sufficient. That is what the verbal consent is, otherwise an implied consent. In the later, we either record the consent by the audio, or if not recording, do I have to have a written female attendant or nurse in case of female, or anyone in a case of male? Yes, of course, the code of medical ethics does not allow you to examine, a male cannot examine a female patient without a female paramedics or their attendant. That is by the code of medical ethics itself. It's not by the law. It's a code of medical ethics. It does not allow a male patient to examine a female patient without a female paramedical or without a female attendant. Traditionally, we post a female in attendant while examining a female patient. Is it going to be vice versa in case of a female doctor attending a male patient? Of course, there are POSCO. You know that prevention of cruelty in workplace. There are complaints by male staff against a female staff for sexual assault. Now you can understand why you need to have a male attendant when a female doctor is examining a male patient. All such events in our country does not happen without a valid background reality that has happened. The valid reality is there are POSCO case against a female alleged by the male. It's true or not, but the case is there in the court. Right, madam?
Thank you, sir. Thank you for answering this question so nicely. We'll move to the next question. And the next question is how, this question is from Dr. Radhika, and Dr. Radhika wants to know how to get consent for below knee amputation.
below knee is a mutilating surgery. When you're trying to get a mutilating surgery, you need to explain why the surgery is indicated for the patient. First point, the why the surgery is there, why we can't salvage the limb has to be told to the patient. And subsequently, what are the complications that you might have? You might have to have clutches or all these things. The time duration for them for the recovery, because subsequent to the amputation, the surgical recovery, and then the post-operative recovery of the wound, and then it will take some more time for them to have their fixators. All these things will have to be explained at the time of surgery. The patient might have some interview or might be having a different work after 2 months. He should be aware, or he should get that permission for that. He will not be able to walk after 2 months. It might take him 6 months, or he'll have to walk with his crutches on. All these things will have to be told to the patient before a surgery is done. At what point of time he can walk back without clutches. It's a time lag between the amputated wound, the stump to heal, and the point when the stump can hold on the calipers. All these things also will have to be told at the time of surgery, because certain things are planned for a person. Today, life is so fast that when somebody walks in for a cataract surgery, wants to go out another 2 hours time, want to be back on work on the 4th or 5th day. The same point is applicable for any mutilating surgery. And if it's going to be below knee amputation, you have to tell them at what point of time the calipers will be available for it. It need not be exactly 4 weeks or 6 weeks. It does at least approximately 6 to 8 weeks or 3 to 4 months. It will have to be given to them.
Thank you so much, sir. Thank you for
Thank you.
answering this question. And that was last question for today's session. So
Thank you.
thank you so
very
much, sir, for taking out your valuable time and for being here at our platform. And at the outset, I would like to thank all the viewers who have joined our platform and who were here throughout. And I hope that this particular session must be helpful for them. The knowledge, the insights that you have shared, that you have pondered upon, we hope that this is going to help them in their near future. So thank you so much for that, sir. So with all your last
you.
comments, sir, we can conclude the session here for today.
Thank you so much for giving an opportunity, IJCP, the one which is Dr. K.K. Agarwal's brainchild.